Hi, everybody. Welcome to the Frank and Lizzie show. Frank, so nice to see you again.
It's great to see you too. It's been a while.
I know. And today we are blessed to be speaking with Karen Ravitz from the Alliance of Wound Care Stakeholders. She is the health policy advisor, and we get to talk to her about an urgent need. So the urgent need is actually a call to action, and it's going to be regarding the Medicare provider enrollment proposals for calendar year 2027 under the home health proposed rule.
Right. And don't be fooled, because even though it says home health, it applies to all of us.
Yeah. So let's dig into that, Karen. Explain to me this home health proposed rule.
Yeah, happy to do that. And thank you for having me. So this is a misnomer. CMS created this massive change housed within the home health proposed rule. But in fact, it impacts all providers regardless of the setting in which you are participating. So what CMS did is they created these new reasons to revoke or deny provider enrollment, and they took away all of these established criteria that impacts all providers. So if you're doesn't matter if you're a physician practitioner, hospital, in a clinic, a DME supplier, even in hospice, all Medicare enrolled providers and suppliers across all sites of service are impacted by these changes.
So not just providers, suppliers as well.
That's correct.
That's huge.
It is huge. And it's super important for all of your listeners to be aware of what CMS is proposing, because there is a direct impact to everybody.
Yeah. So let's go to the basics. Why should we pay attention, especially those of us not in the home health world?
Yeah. So there isn't actually just a single provision that's concerning. Rather, the general thing here is that CMS proposing these broader discretionary authority to give themselves discretionary authority to revoke Medicare enrollment, and they're having fewer defined criteria guiding those decisions. And in some cases, there doesn't even have to be any wrongdoing for CMS to move forward with revocation. It is extraordinarily problematic. And there are specific proposals that they have, and I can state a few if that would be helpful to the listeners. Yeah. But so one of them has to do with retroactive revocation. So there's new provisions that say revocations could be made retroactive, go back to the date of noncompliance. And this creates a potential payment recoupment exposure, where now most, but not all revocations are prospective. They're not retroactive, they're prospective, meaning they're effective 30 days after a mailed notice. But with this proposal, CMS is saying they can go back and recoup payment back to what is often unknown to providers and suppliers, a date of revocation, not just payments made after they receive notice. So if it would be helpful, I can provide an example.
Right. And Karen, when you say revocation,
yep,
explain that to some of us that may not be Medicare lingo wise.
Yeah. So when it means they can revoke your provider enrollment, meaning you can no longer participate in the Medicare program.
Oh, wow.
And this is for individual providers, also health systems, private practices, DME suppliers, anybody across the board.
That's correct.
If there's an issue of noncompliance, they could retrospectively take payments away from you and recoup them, I guess.
Recoup them because they will have already made them, so they can recoup them. That is correct.
Wow.
Okay. And is this because of this fraud stuff that we've been hearing in other areas? Like, is this because people are abusing the system, that's who they're targeting? Or is this kind of like a blanket of everybody?
That's a great question. So the administration is really using fraud, waste, and abuse as sort of the guise to do pretty much everything they're trying to do. And in this case, they're saying, well, we're trying to eliminate fraud, waste, and abuse in the system. It's a program integrity issue. So if you have, let's say a lapse in your licensure, why should we be paying you for claims billed if you are not currently licensed, right? And sometimes that happens. Sometimes a provider might be unaware that there was a lapse in their licensure, but they can then face this recoupment of everything billed from the date their licensure lapsed. And if there's a pattern, then that's a whole other issue where then they can be revoked, have their provider number or provider enrollment revoked. Yeah.
So this is really new grounds for denial.
Yes. They've had this though. Yeah, they've had, again, there have been currently most, but not all revocations are prospective. So they already have some retroactive, issues with recoupment that they can go after you, but not all. And now they're getting rid of the prospective nature, and everything is going to be all of it's going to be retroactive. Yeah.
Wow.
Yeah.
That's going to be very impactful. I thought they were going to try to help more providers come to the market to help us get more help for the patients, but I guess not.
No, sadly.
Well, and I know we spoke before about the limit to new enrollments with home health providers and DME space. And now it just seems like, has that ended, or is that still happening as
There's
well?
Still a moratorium. There's still a moratorium out there for that. Mm-hmm.
All right. Wow. So now we have no new enrollments. We're waiting for those. And then we're cutting out people as well, retrospectively or retroactively. And then is there also something about the geographical areas, like if there's too many providers?
Yes. So that's a great point. So there's another new and expanded ground for denial as well as revocation. And that also includes geographic area. So what does that mean? It means that CMS can revoke or deny provider enrollment where they deem a location to be high risk due to an excessive number of providers or suppliers in a limited geographic area. So that could be like a shared suite or a shared building. It could be that you have a lot of a particular provider or supplier entities in a specific area, but they don't have, and they haven't defined what the threshold is for what counts as excessive or limited. And in this case, remember I said before, you don't have to have any wrongdoing. Here, there's no requirement of an actual finding of fraud. It just means that if they deem to be too many in a specific area, they can revoke your provider enrollment.
Wow.
Yeah. Yeah. So think about all those shared medical office settings or, those kinds of things. Yep.
So I could be operating as ethical as we can. We think we're doing the great job, but because of others around me, I could also face a penalty or a problem with what I'm doing.
Yeah, it's not necessarily a penalty, but they might just say, you know what, there's too many in this geographic area, so we're revoking or denying your provider enrollment.
Well, that's a big penalty.
Or your supplier enrollment, right? Because it applies to both. Mm-hmm.
So this hasn't gone into effect yet, and it will?
Yeah, it has not yet gone into effect. This is all in proposed format. And so there's obviously the opportunity for comments, but I would say there's another issue that I think would be super helpful for your listeners, and you might be scratching your head on this one as well. And it has to do with the abuse of billing practices. So CMS they're taking away existing criteria that they use to evaluate this abuse of billing privileges. And so, today, those 4 criteria are used to, before you can find this pattern or practice of billing abuse, they use that criteria so that you can challenge the agency. If you're saying, well, that's not really true, I'm going to appeal your decision, you can use those current criteria, but they're getting rid of those. They removed them. And so now CMS has all the discretion in the world, largely unstructured, to say that, yeah, you have a pattern or a practice of billing abuse, which, by the way, they defined as, and they've said this, it could just be a simple finding that several claims don't meet Medicare requirements. And in that case, they consider that to be an abuse of billing practices, and they could also revoke your provider enrollment.
It's insane to me.
It's beyond insane. It's like, scratch your head. You're like, what the heck, right?
So, I mean, I guess what can providers do? Because ultimately it sounds like the rules aren't well defined, at least not yet. Hopefully there would be, I mean, they would have to tell us, right? Like, it seems the rules are up to them. We don't know them. It just feels like there's a lot of the unknowns. And even if you think you're practicing in a way that is abiding by the rules, they could at any point in time say nope and retroactively even recoup payments, even if it wasn't. Right. And so obviously that's a high risk situation to invest your time and money into. So what can providers, DMEs, suppliers, health systems do with this?
So there's a couple different things, honestly. I think, starting to have internal enrollment risk assessments, starting to think about, all current enrollments, all affiliated enrollments, map the owners, the managing employees, managing organizations that might be tied to each other, like thinking through all of those relationships, and then build continuous monitoring of licensure and program participation status for owners and key managing personnel, including clinic directors, managers, et cetera, rather than checking only at like the initial enrollment or revalidation periods of time. Like, you can check all of those now, and you can also tighten documentation practices now, not just the core application, but for all ancillary enrollment related forms. You can tighten those practices, confirm the organization can meet the requirements to retain records for 7 years, all of those things. You can start doing that, right? And it's very valuable to do those things. And at the same time, you're also going to want to heighten proactively, dealing with claim auditing, revenue cycle oversight, billing compliance programs. This is, by the way, going to be a huge burden on practices and whatnot. But I would also say that what folks can do is just remember that this is a proposed rule. It's proposed. This rule will not go forward unless, CMS deems that to be a valuable tool for them. You can also submit comments, which is super important. These are in proposed rulemaking format. And again, because it's a proposed rule, CMS can narrow or modify, drop provisions based on what it hears from stakeholders. So if you're going to wait until the final rule to be issued, you're going to be missing a very important opportunity for you to provide feedback in the only formal window that you will have to shape the outcome. So it's super important. Comments are due on the 31st of August by 5 p.m. And again, you have to let them know, why do you object to this proposal? And it could be just there's a lack of criteria. It's too broad. It could be that CMS hasn't provided, enough criteria. What is the geographic threshold for the excessive number of providers? All of these things are things that you can comment on as well. But again, there's a lot of summaries that are out there on this proposal. Review them, see what impacts you. But most important thing is putting in a comment objecting to this massive change in how CMS can revoke provider enrollments.
Yeah. And Karen, where do we go to make these comments?
Yeah, good question. So there's a website called regulations.gov. It's really important, regulations.gov. And when you get onto that website, there are specific, there's a whole, it's like the federal government has a ton of proposals that are out there. So if you type in the search engine, the calendar year 2027, home health, prospective payment system, proposed rule, it should come up with a link to click on to say comment now. And then you can submit your comments that way.
And I think something we can do for our listeners is we'll put the link of where you can click on in the comments to this so that it can make it much easier for you guys, because I think raising our voices and making sure that we're heard is the only way that we're going to try to battle some of this and at least have a little win in terms of the proposed rules for this year. Because we definitely need to bark about this. And it's a little unfortunate that it's, I won't say it's hidden, but it is hidden in this home health ruling that's affecting much, much more than just home health.
Right. And actually, please make comments, because ultimately it's affecting the patient we take care of.
Yeah.
So, yeah.
Great. Well, Karen, thank you so much for joining us today and sharing this timely call to action, if you will. And thank you to the Alliance of Wound Care Stakeholders for always putting the interests of both clinicians and the wound care patients first so that we can advocate as always. So thanks so much.
Thank you for having me.
Karen.
Pleasure. Thank you.